Hello, welcome everybody. Welcome to this ICMLF webinar today. Today we have simultaneous interpretation available in French. Please message Laurence or Alexandra if you have any difficulties or need assistance. To access simultaneous interpretation, click on the globe icon in the Zoom bar bottom right and click on French. We recommend muting the original audio. Bienvenue à ce webinaire de l'ICMLF. Aujourd'hui, nous avons l'interprétation simultanée disponible en français. Veuillez écrire à Laurence ou Alexandra si vous avez des difficultés ou besoin d'assistance. Pour accéder à l'interprétation simultanée, cliquez sur l'icône du globe dans la barre de Zoom, en bas à droite, et cliquez sur Français. Nous recommandons de couper le son original. Welcome, everybody, to today's African Regional Discussion Group. My name is Amanda Woolley, and I will be the moderator today for the discussion. Before we get started with our fantastic panel today, I just want to give a quick overview of the work of ICMLF and a bit of an introduction to us. We're a physician and researcher-based foundation with two key priorities. The first is working towards improved outcomes for CML patients around the world. We do this through raising the bar of CML management through education, and that includes meetings like this, and also over the last 15 years, working through preceptorships, symposia, and through our online knowledge center on our website. Through this, we're trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The second priority for us is harnessing the power of global research. Apologies for that. We're working, of course, towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. Through this, we have our Genomics Alliance and also a TFR Alliance. And we also did a lot of work during COVID around CML and COVID. Currently, we have a hepatitis B survey in preparation, and we're looking at research into pregnancy in low and middle income countries, and also pediatric treatment, and so much more. I hope that is a useful introduction for all of us today. Our discussion today, much anticipated in our previous discussions, I know, is on the 2023 ELN laboratory recommendations, challenges for low and middle income countries, how to get the best out of the CML laboratory wherever you are. We have two case presentations today that are going to give a perspective from Tanzania and from Ethiopia, and our esteemed international experts to respond in discussion. But we're really focusing on these three questions. BCR ALBL1 testing and monitoring, when and how to test and monitor when resources are limited. And then BCR ALBL1 mutations, when and how to look for them when resources are limited. And finally, how to set up high quality testing laboratories when resources are limited, our general discussion. What are your options for testing and monitoring if your center can't set up its own facilities? Before I introduce our speakers, I just want to give a few housekeeping notes for everybody. Please leave your microphone switched off until you wish to speak. This is really helpful for our interpreters particularly, and also for our presenters. However, it's lovely to see people when you're talking. So if you can have your camera on, please do. It's very nice to see people's faces listening when we are presenting and discussing, and it's great to get to know you. We're really keen to have your questions and make this a discussion and have your thoughts as well. You can submit your questions via the chat. So at any point, please feel free to put a question in the chat and we'll come to it after the presentations in our discussion times. But also, if you're willing to come off mute and ask your question, just use the hand raise function and we'll come to you. If you have any questions about Zoom or access or any logistical questions, please send a direct message either to myself or to my colleague Gerald. We both have ICMLF in our name, so you know to find us if you need any help there. And if you need any help with interpretation, as I said before, please send a message to either Alexandra or to Laurence. So without further ado, I would love to introduce our speakers today. We have today with us Dr. Katerina Machova Polakova from the Institute of Hematology and Blood Transfusion, First Faculty of Medicine at the Charles University in Prague, Czech Republic. Katerina is a senior researcher and expert in CML. She's highly sought after for her expertise in and out of the laboratory. She's a contributor to the Management Practicalities module of the ICMLF Knowledge Center, and we're really delighted to have Katerina back with us today. Thank you so much for joining us. Unfortunately, Katerina has an issue with her camera today, so we can't actually see her, but she's here, and I know that she's ready to talk to us all, so that's great. We were due also to have Professor Jerry Radich joining our discussion, but unfortunately he's not been able to join us this evening at short notice, but hopefully he may be able to join us later in the discussion, and we will welcome him then if that hopefully comes through. And our two case presentations today come from Assistant Professor Samuel Kinde Birru and from Dr. Ahlam Nasser. Samuel is Assistant Professor at the University of Addis Ababa in Ethiopia, and he's doing some great work trying to make testing and monitoring for CML much easier, much more accessible in regional areas of Ethiopia. And we like to think if Samuel can make decentralized monitoring work in Ethiopia, we hope others can make it work in other low and middle income countries also. We're really lucky to have you with us, Samuel, and I'm looking forward to hearing your presentation. So thank you for being here. And finally, Ahlam joins us from the Muhimbili University of Health and Allied Science in Tanzania. Ahlam is one of our most active and energetic contributing physicians from the Africa region. She's in our steering committee for these key discussions on CML, and it's always great to have her as part of those conversations. And we're really thrilled that you're presenting today, Ahlam. Thank you. So with that, I would like to invite Samuel to share his presentation. I'm actually going to share his slides for him. So Samuel, if you would like to just get started, and I am putting up your slides as we speak. Okay, Samuel, we can see your ones. Can you come off mute, Samuel? Okay. Just bear with us one moment, everybody. I can hear me now? I can hear you now. I think it's probably easier, Samuel, if I share your slides because they're not going into presentation mode. So I can do that for you.
Sure.
Okay, they should be there. So go ahead.
Are you going to share, or shall I use, or are you going to present it for me, the slides?
Yep, they should be showing now. Can you see them?
Oh, yeah.
Okay.
Sure. Thank you so much. So
that's
directly into the next, please. I would like to briefly let you about the important landmarks of chronic myeloid leukemia in Ethiopia. Probably the diagnosis was done in the early 90s by the then pioneer hematologists, and they were using actually the morphologic aspect, and they have reported that it was the highest proportion of leukemia in the 90s. That's one of the surprising things, which we could get follow up on this data, and we'll see the same thing is happening when the other leukemia has been studied in reference to the CML. Another important landmark is the TKI adherence. Despite the free provision of the drug, the TKI adherence rate is still not really strong enough. As a study being done by our colleagues, it's around 55%, which is one of the most important challenges. This drug adherence could be as a pH meter also for monitoring and evaluating and for potential of PFR clinical trial. Another important landmark is in 2022, among 395 cohort of CML, none of them were evaluated or verified for their molecular remission status. Clinicians were supposed to do molecular tests, but because of several challenges, which I'm going to explain it to you, and most of the time in other low-income countries, they were only using the gross or hematological or symptomatic way of monitoring, which is one of the challenge. And the next year, which is 2023, some colleagues of ours, they identified some of the comorbidities which has been associated with CML, which is the hypertension and HIV, which is a very important paper. You can read it more. And lastly, this year, I and with my colleagues, we have seen an interesting interaction of genetic makeup with that of the TKA response or clinical outcome, which could provide a baseline for further study or exploration in this arena. Next, please. So when and how to screen or diagnose or monitor with limited resources. I had more than 1 hour discussion with Dr. Amaha. He's a pioneer hematologist in our country, and of course with other lab facilities, and with a verbal discussion. And I come across few and very critical informations. If a new patient comes to the hematology clinic, the patient is expected to refer its sample to an overseas laboratory. But when the patient has some financial constraints, and if we do have the gene expert available, of course, the gene expert with its own limitation, the supply chain for the cartridge is really inconsistent. So even though the gene expert is inconsistent, our clinicians and we as lab scientists, we try to focus to maximum use of the gene experts. So when there is an interruption of this supply chain, the only and the worst option is just to wait for the patient until he or she able to save enough money or enough fund to do fish. So you can imagine, despite the patients are coming lately to the health facility, they are also expected to stay for more than 1, 2, or 3, or until 4 months with just simply cytoreductive therapies, like in case of hydroxyurea. Next, please. So another important point is with the challenge which we encounter is the referral of samples. So despite there are multiple agent laboratories in the capital city in Addis Ababa, they have good trial, but still there is an inherent problem. One of the main causes is lack of dedicated person to discuss and to monitor with the hematologist and lab personnel, so that there could be an improvement in the service provision. So some, for instance, very few examples is like, for instance, they provide us with an equivocal results. Of course, the laboratories could be due to some challenges of the shipment problem. Of course, to do fish, there should be enough fresh or viable cells, but due to the unmonitored or uncontrolled shipment, there could be less number of viable cells to get into the interface. So they usually report a very equivocal results. Just for the interest of time, I will just jump into the most important challenges. Another important issue is the turnaround time of the results. For instance, when there are some shipment problems, it could stay up to 10 days. So we don't know exactly when the samples were staying. Is it because of the shipment at the airport or at the customs clearance? We have no idea, but simply our reports stay up to 10 days. So this is obvious, which would overall compromise the viability of the cell for fish and the integrity of also for the RNA for the PCR. So in general, this is where there is an urgent need to conduct quality assessment of even for the sample referral procedures or process. Next, please. So TFR versus lifelong or therapy, what are the key challenges and what are the opportunities? Just to keep in mind that most of the time, which I come across some senior scientists and advocates of the TFR, there is a wrong assumption that most sub-Saharan or the African clinicians or lab persons they don't like to get into the TFR trials. But it is not really that's the case because most of our patients are very young. So we don't want to keep them in a drug. We just want them to fulfill a normal life, a routine life without drug. But there should be, everyone should understand what are the challenges behind this, okay? It's not really fair to keep a patient in a lifelong therapy. But according to the European network or European recommendation or other global recommendations, there should be a very stringent platform of real-time PCR or quantitative real-time PCR. And this real-time PCR should be very reproducible, which means has to be harmonized to according to the international scale. And at the same time, it should be very short enough with reference to the result reporting or turnaround time. But when we come across our setup, despite we refer our samples, we are suffering from a long-term TAT. And at the same time, these different laboratories are sending their samples to a different overseas laboratory. So there is a problem with reproducibility of the results. Another key challenge is the patients are expected to come to visit the health facility every 1 month, at least for the first few months, to monitor it closely. If there is a relapse, so that they will be immediately primed on the drug. But let alone every 1 month, even for the regular drug fill up, which they are expected to come every 6 months, there is a challenge. That's the problem why our adherence problem is being very, very significant. So another important point is, in order to get into the TFR trial, there should be a very objective and concrete quantity PCR. But as I have mentioned, most of the laboratories are sending to overseas laboratories, which means the baseline of PCR ABL is really inconsistent. Another important point is the late diagnosis. Our patients are coming after passing through at least 3 referral hierarchy: primary, secondary, and tertiary health facility. And at the same time, they are coming to the actual hematologist after the disease has already been established, which means after there is an advanced stage, high so-called score, which means there is a high tendency of relapse if these patients are put on TFR according to the recommendation. So how many are going to be candidate for the TFR? Probably maybe 10 to 20% with low risk score. So this could be eligible, but keeping in mind that could this 20% of subjects able to afford to visit the health facility? This is another challenge. Next, please. So what are the opportunities? The opportunity is, as I mentioned, we have really good clinicians, hematologists, very dedicated hematology clinic division. We have also good availability of drugs. So this is one opportunity if we think of about TFR. but still the challenge is the need to establish, at least at the central level, the quantitative real-time PCR in cytogenetic platform. Next, please. So this is the data which is not really published. The manuscript is on progress in collaboration with the Leipzig University Hostel Hematology Department. We did some tests, some assessments. So just briefly, we can see how the data looks like, how our landscape of CML patients is. For example, in the figure 1, there is a prolonged TKA therapy, but there is a slow response. The same thing has already been reported in some East African journals. At the same time, in figure 2, look, there is a disparity or differential sensitivity among the different types of transcripts. Figure 3, when we adjusted for age, there is a still differential sensitivity for the gender. And when we look on the figure 4, despite longer duration of therapy, look, imagine some patients goes up to 10 years of treatment, but look how many are with the deep molecular response. Next, please. So when we come across this type of challenges, we were opt to design an innovative approach without compromising significantly the test platform. So this method is just a qualitative PCR. Used to be as a screening, it's a multiplex PCR. So we just evaluated how this in-house multiplex PCR could potentially address the diagnostic and prognostic challenges that we've been suffering. So this journal has been already published, and you can go further for the detail. Next, please. So just to briefly talk about the overall multiplex PCR, which is an in-house is, we use, of course, it's been already published primers. These primers or multiplex PCR are able to address almost all or majority of the transcript type for the BCR ABL. So our evaluation was to assess how the multiplex PCR can be transformed or can be interpreted as a semi-quantitative, not exact quantitative, but as a semi-quantitative. So when we evaluate this data against the gold standard, which is against the quantity PCR, of course, with certified plasmids, it was very interesting results. The area under the curve you can see is almost 0.93, and also the cutoff, which is the maximum sensitivity, specificity, and maximum level of accuracy, is almost 0.6% international scale. Next, please. So having said this, we just started to design the approach of how we can able to scale it up and able to establish at the peripheral. Of course, at the central level, we don't have to compromise the quantity PCR, but at least for the patients at the periphery, we can establish this easy approach. So at the research level or at the research setup, we prepared in-house reagents, and this in-house reagent is just a mixture of everything, master mix, for 10 subjects or for 10 samples. So the only thing that the health facility, which is the peripheral health facility, is expected is to add the samples, then just run the PCR. One thing, it doesn't require intensive resources. It doesn't require separate room like master mix preparation and so on. Another important point, based on a very recently released compact gel electrophoresis with underneath with some sort of lead light, we were able to get the gel image without a need for an expensive camera. So this is what we've been starving and what we've been trying to establish. But very unfortunate, we cannot get enough fund to enhance and to expand to a peripheral laboratory, let alone. So this is why we need your potential advice or suggestions that you can. Next, please. So the majority of milestone is during the 6 to 12 months, which normally expected. Our gel electrophoresis provides enough cutoff because with sensitivity specificity up to from 0.1 to 1% international scale. This is the range that the technique can able to detect. For example, if we consider at 0.1% international scale, the sensitivity is 100%, though the specificity and accuracy is being lower. So this can potentially be used as a potential to screen and to diagnose, which was at the early time. By the way, when we start to evaluate or when we start to embark into this project, most of our German colleagues, they consider that no, if a patient starts a drug, there is no way that you can detect by gel electrophoresis or by multiplex PCR. But unfortunately, it was not the case. Despite patients were taking the drugs for more than 2, 3, 4, 10 years, we were able to detect these gel electrophoresis. So the gel electrophoresis, if it's been well established, well evaluated, it can provide also screening as well as prognostic value. And very interestingly, European Leukemia Network Journal, they have recommended even in a resource-limited setting, it's very essential to rule out relapse or even to assess non-adherence in their reference number 82. So at the same time, this approach can enhance the impact of the TKML available through GPAP in most low to middle income countries. Next, please. So, is it feasible to establish in-house multiplex PCR in a similar setup that currently rely on sample referral and gene expert for diagnostic or prognostic purpose? This is a potential discussion area which I would like to get your feedback or your compliment. Yes, we say it's short TAT and it's cost effective and it can be easily scalable to a peripheral laboratory. So what are the additional challenges? What specific strategies could we use or could we leverage or can we get an experience from you in order to scale it up this region? Because at the beginning, we were very passionate that this method can also be used to send specimen, reagents. Once the multiplex PCR been established, the only thing is from the central laboratory, we just simply ship the master mix so that people can do it wherever they are. The patient should not come to the center. And how can sample reference process can be improved? For example, for mutation, of course, mutation analysis a must. Yeah. So one important point which we have learned from this is if the samples are prepared locally, which is what I have done in Addis, I have just washed them, the red blood cell, lyzed them, and also digested them using locally available detergents. So it can enhance the integrity of RNA without compromising during the shipment process. Another important point that we have learned, I haven't shown this in this slide, but even for fish, we culture them, we just stop them at the interface phase, then we fix them and send them to Germany. There is no problem with the shipment once the cells be in the interface phase. And finally, I asked the guys for the feedback, and they said that everything was perfect, and they did their probe assay, and the result was fine. So these are something what we can play when we are still on the referral specimen or for the specific mutation analysis or advanced next generation sequencing. So with this, next please.
Okay.
With this, like to mention my special gratitude, my mentors, Dr. Amaha, who had been throughout all the procedures, Dr. Rowley from the Ahlam Nasser Research Unit, who had been helping you with the establishment, Dr. Michael Cross from University Clinic Leipzig, who had been providing generously all the reagents, and of course my MSc students, Saifo and Azib, and also most hematologists, nurses, and I wish really a successful TFR startup for our CMA. Thank you so much.
Thank you, Samuel, for that presentation. Really interesting stuff, and I'm sure we'll have lots of questions from the audience. Please do put them into the chat for us, but I'd like to invite Katerina and also Ahlam to come off mute and offer their reflections, any insight into these questions. I'll just leave it on this slide, if that's all right, Samuel, with the questions that you offered. But Katerina, can I come to you first?
Yes, thank you very much. Hello, everybody. Sorry for that my integrated web camera doesn't work. I don't know why, but I hope that you hear me well. Samuel, thank you very much for a great presentation and an overview about the situation in your country. And I made several notes and yeah, coming back to your questions. So if I understand well, I think that your in-house multiplex PCR looks very well and the sensitivity is pretty high, right? So I think that of course this method is great for diagnosis, but I think that it can be also used after the TKI start because the sensitivity of multiplex PCR is pretty high. So I understand well that your access to real-time PCR, so you do not have established quantitative real-time PCR to report PCR-able results in the international scale. Am I right? Just to
Correct.
be sure. Okay. The other thing, of course, you mentioned GeneXpert. So do you have this opportunity to work with GeneXpert and the kits enabling to report PCR-able data in international scale?
Sure, absolutely. GeneXpert available despite interrupted supply chain of the cartridge.
So the machine is there, and the of course the cartridge you may yeah, the cartridge, the cost is fine to perform the real-time PCR analysis, or is there the limitation to buy the cartridges, or?
Absolutely.
This is the limitation, that the price is quite high for patients, because patients need to buy the tests. Am I right? Do I understand it well?
It's been subsidized by the government.
By the government, okay.
It's been subsidized, but the problem is still there is supply chain management problem due to some foreign purchase procedures are really bureaucratic, to be said.
Okay, I see. So the optimal way for you is to have your in-house methods. Am I right?
Sure.
This is the way you would like to go. Okay. So you have well established your in-house multiplex PCR. I think this is absolutely great for diagnosis in my eyes. But as I mentioned before, also for prognosis, at least you will know whether the patient achieved complete cytogenetic remission, because we know that complete cytogenetic remission is let's say equal to 1% of BCR-able at international scale, which is the sensitivity of your in-house multiplex PCR is there. Yeah, so at least you would know this. And in some cases, because there is definitely the variability in PCR analysis, multiplex PCR analysis, and it highly depends on the quality of the sample and RNA, etc. So in some cases, you may reach the sensitivity as 0.1%, right?
Absolutely.
Which is similar to major molecular response.
Yeah.
Which may be great also for let's say for patients who would like to, and who are you pass the criteria to stop TKI therapy.
Absolutely.
Because so this may be also fine for these patients, because you will see after you will see when the patient is losing the MMR, you will see nicely visible the band. So still you can get the information quite quickly. So in my eyes, I don't know your in-house multiplex PCR in detail, But with the sensitivity you showed us, I think it may work also for TFR management. Yeah, it may work for TFR management. I was also thinking. Sorry, I was also thinking about the old, let's say, old-fashioned method before real-time PCR era, which was competitive PCR, which is just you need also just the PCR cycler and electrophoresis, like agarose gel. And this is also cost-effective option, and the accuracy of this competitive PCR was pretty nice with real-time PCR, right? Real-time quantitative PCR. So this is other option, quite effective option, cost-effective option, special in cases of patients who may stop TKI. Yeah. So
thank
okay,
you,
sorry.
Katerina.
Okay,
no,
sorry.
I think that, no, absolutely. Thank you so much. I think this is all so valuable for everybody. I just want to sort of jump in to encourage our audience to ask questions, and also maybe think about some of your own patients who this is relevant for at the moment. And if there are particular questions, then you're very welcome to ask those too, or share reflections on your own setup. How would this work in your setting? And I'd love to hear Ahlam's experience as well in Tanzania, and reflections on what Samuel has shared. Is there anything, Ahlam, that stood out for you, or different ways that you're responding to these challenges?
Thank you very much. Thank you, Samuel, for an excellent presentation. As someone working in resource-limited setting, I do concur with you. Some of these challenges are quite realistic, and our practice is generally driven by what is available. So I do commend you and your team for coming up with this in-house multiplex PCR, not only for diagnosis, but also it does seem to have good sensitivity for picking up at least complete cytogenetic response, and even molecular, because I remember your sensitivity is around 0.1%, which is almost molecular with major molecular response, which I think is excellent. Maybe going around the questions of how you can go large scale, I was wondering with the current available Cepheid kits, have you reached the stage of where you were able to compare the cost in terms of realistically everything that is needed to perform the test compared to the everything that is needed to perform the test on the gene expert? I think having those numbers might be beneficial, especially since the gene expert is being subsidized by your government. You can make a case with the policymakers. And one way to go around this is, at least for Tanzania, what we have thought is having patient advocacy group. And we have recently registered the Blood Cancer Foundation of Tanzania, which is driven by the patients themselves. So we have seen this working in Kenya, where their foundation, the patient advocacy, is very strong, and it's able to demand their rights and the government to prioritize some of these tests. So that might be one way you can consider getting the stakeholders, the government on board, showing the evidence of the cost analysis, because the government will always want to save money. So I'm sure that will be interesting when you have the numbers. And also having patient advocacy group to drive this. I think that's one way you could think about.
Thank you so much for the compliment.
Yeah, thank you, Samuel. I'd love to come back to you for the last word on this discussion before we hear Ahlam's presentation. Is there anything particularly that you any wisdom that you would like to share with people who are maybe thinking of doing something similar in their own setting? Any kind of key tips that that perhaps aren't in the journal article that are still important, do you think?
Just especially with regard to the cost, I didn't mention it during my presentation for the interest of time. There was a significant difference with regard to the cost when we calculated it, excluding the overhead cost. Per patient, it might cost like 5 to 6 USD, as compared to the referral sample like 120 or 130 USD. So it's really significant impact for the patient as well. So in addition to what Ahlam mentioned about convincing the physician. But one of the challenges which we come across is when we apply for the government fund, when they send it for the reviewers, they usually consider that this is a niche or this is a small group of patients as compared to the other healthcare problems. That's the challenge. But we have been trying to apply for a local fund.
Yeah, absolutely. And coming back to Ahlam's point about involving the patient advisory groups, and I'm just wondering what the anecdotal feedback from your patients has been around this this change or this approach. Do you have any feedback or stories from the people who you've been working with?
Really, thank you. This is very important take-home message, which I'm going to advocate to our patients. We didn't actually advocate this method to our patients, but we have also already a group of CML patients. So probably that could be a very potential entry point to advocate directly to this patient to the government. That is a very strong, good strategy.
Thank you. That's great. Thank you so much for your presentation, Samuel. Really interesting introduction to this area and getting us all thinking about this topic. Please, we do want your questions. Everybody else who's listening, put them in the chat, raise your hand, and then I know that you're wanting to come in later on. We'll have a bit of time for open discussion after Ahlam has presented. If you'd like to get your slides ready, Ahlam, that would be fantastic. But just an encouragement to everybody. We would love to have your thoughts, reflections, how you can apply some of the learning that we're covering here this evening. But I'll pass over to Ahlam. Thank you.